Hello, this is Dr. Kim Jeongul. Today's topic is the Introduction to Orthodontic Differential Diagnosis Part 1. The necessary data are analyzed and the problem list is developed for orthodontic diagnosis. Any pathological findings should be controlled prior to orthodontic treatment. Then the orthodontic problems are prioritized in accordance with the patient's needs. And if the patients are satisfied with possible treatment plans, we can proceed to treatment. Orthodontic diagnosis can be largely divided into three parts. 1. Extraction or non-extraction. 2. Which teeth to extract. 3. How to treat. Various aspects need to be considered in order to decide whether to extract or not. Such are aesthetics, lower incisor position, interincisal angle, arch length discrepancy, and overjet. But are these enough to make extraction decision? MEAW Orthodontics first looks at the combination factor and posterior occlusal plane. As you can see, there are a lot of variables to consider. Other variables are growth, arch width, canine and molar keys, sinus pneumatization, condition of third molars, premolars, and other teeth. Extraction vs. non-extraction is still one of the most debated subjects. And there was an important debate between Angle and Case in the early 1900s on this issue. Angle believed in the normal occlusion theory and emphasized non-extraction treatment. So most of his patients were treated with non-extraction approach. On the other hand, Case, a student of Angle's, suggested the judicious use of extraction as a practical procedure. But still, only 12 to 15% of his cases were treated with extraction. The climax of this conflict was a fierce debate in 1911 between Case and Dewey. And this is still an ongoing debate today. There is no royal road to the orthodontic diagnosis and treatment. A clear set of rules does not exist, but it is necessary for us to develop such rules. As Moyers stated, orthodontics use the accumulated knowledge of craniofacial development within two logistic frameworks: understanding past growth and anticipating future growth. Diagnosis studies what has happened, and we can make diagnoses based upon the evaluation of past cases. But all treatments are in the future, which means that treatment does not necessarily proceed in the same direction as diagnosed. I believe that orthodontic diagnosis is the most important aspect of orthodontic treatment. Some people believe that there is no need for orthodontic diagnosis, but I believe that orthodontic diagnosis is the most important, followed by bracket positioning and wire bending. Many cases may not require wire bending at all. Orthodontic treatment follows this sequence. And we are going to focus on whether to extract or not in orthodontic diagnosis in this lecture. And then next lecture we'll discuss the methodology of treatment. I reviewed the literatures for guidelines for non-extraction treatment, but there was only a few. Among those, Setlin's guideline is the best organized. 1. 8 mm or less of crowding. 2. Severely mesially and lingually tipped posterior teeth, and in constricted arches. 3. No requirement for stability or aesthetics, but I believe stability and aesthetics is still required. 4. Cooperative patients. 5. Growing patients. Of course, any patient wants non-extraction treatment, but there are limitations. 1. Upper molars can't be bodily distalized, especially if the upper second molars have erupted already. 2. Arch can't be expanded in any direction. 3. Lower canine width can't be increased. 4. Long-term retention is necessary for stability. The biggest problem in non-extraction treatment is an aesthetic problem due to lip and teeth protrusion. And there is a relatively high relapse potential due to increased intercanine width. Therefore, many orthodontists choose to extract teeth. Here are the common indications for the extraction of the first premolars. 1. In general, there should be more than 12 mm of crowding in each arch. This would indeed require extraction. The size of the first premolars is generally about 7.5 mm, so the extraction would provide 50 mm in each arch, which is enough space for alignment of more than 12 mm of crowding. 2. In cases of a bimaxillary dental protrusion with an interincisal angle of less than 120 degrees. Instead, some people measure loan to mandibular plane angle or FMIA. 3. Also, cases with moderate crowding of 8 mm and an interincisal angle of 120 degrees would require a consideration of extraction. But the extraction of the first premolars may bring about the following problems. 1. Control of deep overbite is difficult because both the upper and lower incisors are extruded, as they are retracted during space closure. 2. Requires greater amount of torquing in retraction of incisors, and it is difficult to achieve bodily movement. 3. Complete closure of the extraction space and the maintenance of root paralleling are not easy. 4. Complete closure of the incisor space becomes difficult. 5. Extraction space opening is a common problem. 6. Due to the reduction of the arch length and tongue space, function of the tongue may become impaired. 7. May cause a dishit in profile and produce an unnatural smiling. 8. Even after the extraction of premolars, the third molars often become impacted and require extraction. Then a total of 8 teeth will be lost. It is always advisable to keep 28 teeth in dentition, but only 24 teeth are likely to be left after orthodontic treatment. McLaughlin stated that the dilemma of extraction vs. non-extraction should be looked at in relation to TMD. He claimed that the extraction of premolars can lead to TMD and bring about the following problems. 1. Collapse of the vertical dimension. 2. Flattening of the facial profile. 3. Excessive anterior interference. 4. Posterior condylar displacement. Witzig and Spall also discussed the drawbacks in first premolar extraction. 1. Reduction in vertical dimension. 2. Over-retraction. 3. Upper incisor retroclination. 4. Bite deepening. 5. Anterior interferences. 6. And TMD due to posterior condyle displacement. Extraction or non-extraction is still a debate, but non-extraction has become a preferential treatment recently. I pay attention to these 3 conditions in non-extraction treatment. 1. The profile should be acceptable. 2. Lower anterior crowding should not be severe. 3. And the lower incisors should not be too proclined. Only when these conditions are met can non-extraction treatment be performed. The treatment mechanics have to be considered as well. 1. Aesthetics can be evaluated by many aspects. You can use align to see if the lips are protruded and consult with the patients on the change in profile. Aesthetics can also be evaluated by nasolabial angle, relative protrusion of the upper lip to the true vertical line, passing through subnasal, mentolabial angle, and protrusion of the lower lip. Nasolabial angle and mentolabial angle are also closely related to the position of the upper and lower incisors respectively. 2. Lower anterior crowding. Many Class 3 malocclusion patients present upper anterior crowding, but no lower anterior crowding. And these patients can be treated with non-extraction approach. However, if there is a lower anterior crowding, the likelihood of extraction treatment increases. 3. Then the lower incisor position is determined. You should first look at the inclination of the upper and lower incisors. The patient has yawn to FH of 119 degrees compared to the ideal value of 114 degrees. IMPA is 106 degrees compared to the ideal value of 90 degrees, indicating labioversion of the lower incisors. Interincisal angle is 113 degrees compared to the ideal value of 130 degrees. Due to labiovision of both the upper and lower incisors, the patient shows protrusion of both the upper and lower lips. But the lips are normal with regard to the L-line. Therefore, the amount of crowding will be the important factor in this case. 4. Treatment mechanics. The use of Class 2 elastics results in posterior movement of the upper incisors, while the use of Class 3 elastics results in posterior movement of the lower incisors. These elastics can be used on mini-screws or hooks on appliances. Class 2 mechanic also results in labioversion of the lower incisors. So the key to Class 2 mechanics is the lower incisor position. On the other hand, Class 3 mechanic results in labioversion of the upper incisors, which means the key to Class 3 mechanics is the upper incisors position. Therefore, in cases of Class 1 or 2 malocclusion with slight lower anterior crowding and protrusion, there is a higher possibility of extraction treatment. Let's review with this diagram. The x-axis represents the lower incisor proclination, and the y-axis represents the lower anterior crowding. As in lower left, if there is no or a slight lower anterior crowding and normal lower incisor inclination, non-extraction treatment is possible. However, as in upper right, if there is a severe lower anterior crowding and severe labioversion of lower incisors, the likelihood of premolar extraction increases. Also, there is a possibility of extraction treatment if the lower incisor position is normal, but the lower anterior crowding is severe, or if there is no or a slight lower anterior crowding but labioversion of the lower incisor is severe. When there is no or a slight lower anterior crowding, we can think of several treatment options. The first and foremost is non-extraction. Then you can consider the upper second molar and lower third molar extraction, if the upper third molars are in a good condition. In cases with lip protrusion, only upper premolar extraction can be considered. And if the lower anterior crowding accompanies arch constriction and overall lingual inclination, non-extraction treatment can be attempted. The discrepancy mesial to the first molar is called the anterior discrepancy, and that distal to the first molar is called the posterior discrepancy. In case of an anterior discrepancy, premolars or other anterior teeth can be extracted. On the other hand, in case of a posterior discrepancy, posterior teeth need to be extracted. So what happens if there is a posterior discrepancy? Because there is not enough space in the posterior segment. Mesial angulation and overruption of the first and second molars can be caused by the third molars. And therefore the third molars have to be extracted. This posterior discrepancy can in turn lead to anterior discrepancy. Combination factor should also be considered. Combination factor is a sum of ODI and a PDI. Patients with long faces have low CF, and there is a greater possibility of extraction. On the other hand, patients with round faces have high CF, and the likelihood of non-extraction approach increases. If the UOP and POP are normal, they should be maintained. And the steep UOP and POP should be changed to normal. In MEAW orthodontics, it is claimed that class 2 and 3 molar occlusions have a close relation with posterior discrepancy and POP. In general, there is a steep POP in class 2 molar occlusion and a flat POP in class 3 molar occlusion. In other words, in class 2 molar occlusion, the overruption of lower molar limits forward movement of the mandible. In contrast, in class 3 molar occlusion, the overruption of upper molar promotes forward movement of the mandible. Many orthodontists considers only the anterior vertical dimension in class 2 and 3 molar occlusions. The anterior vertical dimension increases in class 2 molar occlusion, while it decreases in class 3 molar occlusion. However, posterior vertical dimension should also be considered. In class 2 molar occlusion, the posterior vertical dimension decreases and the POP becomes steep. In class 3 molar occlusion, the posterior vertical dimension increases and the POP becomes flat. In diagnostic thinking process, non-extraction should be considered first. Upper and lower third molar extraction and upper second molar and lower third molar extraction can be regarded as non-extraction, provided that 28 teeth are to be aligned in the dentition. Also, reproximation can be performed to make room for alignment in non-extraction treatment. Then the premolar extraction can be considered. And there are many different options of the first and second premolar extraction. There are also cases with unusual extraction when there are problems with the incisors or the first molars. We go through model analysis, CEF analysis, and aesthetic analysis for orthodontic diagnosis. And the first thing to consider is whether to extract or not. This subject will be constantly discussed in next lectures. Thank you for watching.